Thank you so much for being here today for our Ask the Experts event. This is a fantastic joint initiative between Council on the Ageing New South Wales and the Sydney Mechanics School of Arts, and we're so glad that you've been able to join us this afternoon. We're very fortunate to have 3 experts join us today to help us look after our health from top to toe. To start us off, we have Juliette Tran, who will take us through all the important aspects of oral health as we age. Juliette is an oral health therapist at Concord Hospital, where she works with older individuals in a variety of settings, including the community, residential care, and acute care as well. Her focus is on improving oral health, particularly for older people, as she recognises the critical link between oral health and the prevention of systemic diseases. Juliette is passionate about health promotion and is committed to building connections with older groups. Her approach is centred on delivering excellent care while providing personalised education and treatment to advanced oral health. Please join me in welcoming Juliette to the stage.
Good afternoon, everyone. Thank you for inviting me today to the Seniors Monthly event organised by the Council of the Ageing New South Wales and the Sydney Mechanic School of Arts. Today we're going to talk about oral health. I'd like to also acknowledge the traditional custodians of the lands that we're meeting here today. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal people and their ongoing cultures and connections to the land and waters of New South Wales. I also acknowledge and pay my respects to our Aboriginal and Torres Strait Islander people and colleagues joining us today. So today I'll be talking about the importance of oral health in ageing, common oral health conditions of older people, and also practical tips for maintaining good oral health. So the importance of the mouth. I'd like to start with this activity, and if we can all say together, she sells seashells on the seashore. Now let's try and say it faster. She sells seashells on the seashore. And now let's try and say it without the tongue touching any of our teeth. So as you can see, it's very difficult to pronounce specific words without our tongue touching the teeth. So good oral health helps us to perform many of our daily functions. Teeth and oral structures help us to pronounce words. We can also enjoy eating a variety of healthy foods when we have a healthy mouth. Swallowing foods involves multiple muscles of the mouth, saliva and other oral structures working together to help push food from the oral cavity through the esophagus. A mouth free of oral disease also allows us to carry on with our daily activities without any pain and discomfort. We can also enjoy socialising with our friends and family without embarrassment. So what is the mouth and body connection? Cardiovascular disease can also occur when chronic oral infection can complicate the medical management of health illnesses, such as cardiovascular disease. If you don't keep up with oral hygiene or you leave cavities or gingivitis untreated, bacteria in the mouth can travel and block blood vessels and increase the risk of getting heart attacks. Lung infection. So in a healthy mouth, over 700 different bacteria coexist. Some of these are beneficial and others can be harmful. It's when the bacteria grow out of control that they can pose problems for our teeth, gums and the rest of the mouth. An overgrowth of the harmful bacteria can cause tooth decay, inflamed, and bleeding gums. The bacteria can further spread to your lungs, and for example, this bacteria can cause bronchitis and pneumonia, and also worsen conditions such as emphysema and chronic obstructive pulmonary disease. Alzheimer's disease is also another connection to the mouth, where recent scientific analysis suggests that bacteria that causes gum disease are also associated with the development of Alzheimer's disease and related dementias, especially vascular dementia. Bacteria and the inflammatory molecules they make can travel from the infections in the mouth through the bloodstream and to the brain. Once in the brain, those bacteria release enzymes that can destroy nerve cells and in turn can lead to memory loss and eventually Alzheimer's disease. Diabetes. So how can diabetes affect our oral health? Through gum disease. If gum disease is not treated, it is harder to manage your diabetes. There is increasing evidence of a two-way relationship between periodontitis, which is also known as advanced gingivitis, and diabetes. The risk of developing periodontitis is greater in people with diabetes, particularly when the blood glucose levels are not within the recommended 4 to 7 millimoles per litre. Common oral diseases and problems in older adults. Tooth decay is a diet and oral hygiene related disease that affects the tooth and also causes pain. Tooth decay is a destruction of tooth structure and can affect both the enamel, which is the outer coating of the tooth, and the dentine, which is the inner layer of the tooth. There are 4 main criteria which are required for tooth decay to occur. So first we need a tooth, which includes the enamel and the dentine. Caries causing bacteria, a fermentable carbohydrate such as sucrose, and this needs to happen over time. So tooth decay occurs when foods containing sugars and carbohydrates such as breads, cereals, soft drinks and sweets, fruits, cakes, pass over or are left on the teeth surface. Bacteria in the mouth then digest these foods, creating acids. The bacteria, acid, food and saliva combine to form plaque, which clings to the teeth. The acids then quickly dissolve the minerals from the tooth enamel surface. And if this cycle continues without opportunity to replenish the minerals, then a cavity of the tooth may form. So gum diseases are also associated with general health problems such as diabetes and cardiovascular disease. In general, periodontal diseases are triggered or caused by plaque bacteria, but can also be affected by our health, family history, and poor oral hygiene, or smoking and diet. So in its early stages, we have the gingivitis occurring, which is the middle picture you see on the right here, on the left here. Only the gums and the teeth are affected at this stage, and the disease process is reversible then. So the symptoms that we want to look for are swollen, red gums that might bleed when we brush, and in between our teeth, those spaces might bleed as well. Bad breath or metallic taste may also occur at this stage. So what happens in periodontitis, which is when gum disease advances, is that it's no longer just the gums being affected. It now includes the structures underneath the gums, under the gum line, that include the bone and the supporting ligaments of the tooth that hold the teeth securely in place that start to break down. And as a result, the bone and ligaments become damaged, destroyed, and if the disease is left untreated, it can eventually lead to tooth loss. Another common oral health condition is dry mouth. So dry mouth can occur as we age, associated with a reduced saliva flow, or our salivary gland is not producing as much saliva as it used to. Saliva has antibacterial properties, so if the quantity and the quality of the saliva is depleted, oral diseases may develop more rapidly. So what we can do to help is maybe choose sugar-free gum to assist in promoting the production of saliva. Dry mouth is also very uncomfortable, unpleasant, and can impair taste, affect our chewing and swallowing, and also speech. It's associated with rapid dental decay, and in those with reduced salivary function, some may experience an increased risk of acquiring aspiration pneumonia. So I'd like to speak about mouth ulcers and oral cancer screening as well. Ulcers are usually quite painful. They can appear on the gums, sometimes between the lip and the teeth. Aphthous ulcers are also very common and affect 1 in 10 people. The cause of aphthous ulcers is unclear. They can occur maybe from stress, poor health, or food irritation. Usually, ulcers will heal from 10 to 14 days. It is important to monitor the healing of ulcers, and if they persist for longer than 10 to 14 days, to please seek assessment from your medical or dental practitioner. So, mouth cancers. The most common sites of mouth cancers are the lips, tongue, and floor of the mouth. Smoking and drinking alcohol are known risk factors. Mouth cancer can be cured if treated in its early stages. The symptoms of a mouth cancer can include a visible mass or lump that may be or not painful, an ulcer that won't heal, a persistent blood blister, bleeding from the mass or the ulcer, loss of any sensation in and anywhere around the mouth, trouble swallowing. You may have also impaired tongue mobility, difficulty moving the jaw, some speech changes, loose teeth and or sore gums, altered taste, or swollen lymph glands. So as we age, it's very important to become familiar with any changes occurring in and around our mouths. This picture shows you how a simple 8-step oral cancer screening exercise can help us to detect these changes. So we recommend doing this at least maybe once a month, just to check around your mouth for any symptoms. And also, again, as before, please see your medical or dental professional for advice if you do notice any of these changes. And I'd like to end with some messages for a healthy mouth. So I've broken these down into 5 tips. The first one will be to eat well. Tooth decay is related more frequently to the frequency of sugar intake rather than the total amount of sugar eaten. So we can reduce the frequency of eating sugary and sticky foods like biscuits, cakes, and sweets. We can also eat a variety of nutritious snacks daily like fruits, nuts, and yogurts. Eating from a variety of food groups such as vegetables, fruits, dairy, meat, cereals, and grains to support oral and general health. Eating fresh, crunchy foods such as apples, celery, carrots. We can also slice these foods into smaller pieces if we have difficulty chewing. And eating meals or snacks containing milk or cheese can help to reduce causes of tooth decay. Drinking well. So fluoride in tap water helps to strengthen our teeth and reduce acids that initiates tooth decay. So we should be drinking tap water daily. In most places in New South Wales, the water supply does contain fluoride. We should also drink water after our meals and snacking, and also after taking medications. Keeping the mouth moist by frequently rinsing or sipping on water throughout the day is important. And avoiding sugar in tea and coffee, reducing the intake of caffeinated drinks also. We should also limit the intake of acidic and sugary drinks such as fruit juice, cordial, or soft drinks. So cleaning well. Poor oral hygiene allows the bacteria in dental plaque that coats our teeth to produce acids and other substances that might damage our teeth, gums, and the surrounding bone. The daily removal of plaque and maintenance of sound dental health practices are the key aspects to preventing oral diseases. Toothbrushing with a fluoridated toothpaste, a soft toothbrush, is the most effective and economical method of physically removing plaque from the gums, tongue, and teeth, and or dentures. Fluoride in our toothpaste helps to protect natural teeth by remineralizing and strengthening the tooth enamel. So how do we care for our natural teeth? We should be doing it at least morning and night, so twice a day using a soft toothbrush on our gums, teeth, and tongue as well. And the amount of toothpaste we should use is only a pea size. So not the whole strip of toothpaste on the toothbrush. Pea size is an adequate amount. And I'm not sure if everyone here does it already, but we should be spitting out our toothpaste after we brush and not rinsing with water. Does everyone here do that already? Yes, very good, excellent. Also, reminders to changing a toothbrush. So with every season is a good indicator to when we should be changing our toothbrush. Also, if we've had an acute infection, such as cold or flu, it's a good idea to change our toothbrushes over as well. And lastly, if the bristles of the brush become visibly frayed, then definitely change to a new toothbrush. Using dental floss or interproximal brushes, these are the tools that we use to clean in between our teeth, should be used at least once a day. Cleaning dentures. If you do wear dentures, you are at a risk of developing fungal infections. Fungal infections might be associated with wearing the dentures all day, especially overnight, poor denture hygiene, and denture plaque buildup as well. So we should also be cleaning our dentures daily using a denture brush and liquid hand soap to remove plaque from the surfaces. So we should not be using toothpaste on our dentures, as the toothpaste contains abrasives, which might scratch the surface of our denture and allow plaque to stick to that more easily. So only use the hand soap and a denture brush when cleaning dentures. Making sure to hold dentures carefully so that they don't drop, as they can be expensive to replace. And brushing our gums and tongue with a standard toothbrush to remove plaque from the mouth as well. So remember to remove your dentures overnight, storing them in a container dry. Previously, we have been storing dentures in a cup of water overnight, but if you do that at present, I would urge you to tonight try and store your dentures dry in a cup, as that wet environment does promote fungal and bacteria growth. So we do recommend to store them dry. The fourth tip we have to maintaining good oral hygiene is playing well. So as with maintaining general health, exercise is very important, and exercises for stronger cheek, tongue, and salivary flow will help to maintain a moist mouth, as shown here. So let's all try these exercises. The first one on the left here is where we'll put air in our cheek and push it from side to side. The second exercise, let's run the tongue into the inside of the cheek and push it left to right again. This will help to exercise our tongue muscles. Massaging the sides of the face, so we'll use a circular motion to improve the saliva flow, because the big salivary gland does exist on the side here, and as we massage it, we'll promote that saliva production. And finally, if we can all use our facial and lip muscles to say ooh and ee, just alternating between those two, that will help to strengthen our facial muscles. So try and do this at least once a day, maybe when you're watching TV, or just, whenever you remember. And the final tip to maintaining good oral hygiene will be to stay well. So we can stay well by doing a few things: visiting your dentist regularly, even if you do wear dentures. Everyone has different needs, so please talk with your oral health professional about how frequently you'll need to see your dental professional for regular checkups and cleans. Other things we can do to stay well are protecting your face and body from the sun with sunscreen, lip protectant, a hat, clothing, and sunglasses. Use sugarless medicines where possible. It might be useful to check with your GP or pharmacist if there are sugar-free alternatives to your medications. And using walking frames and balancing exercises to reduce falls and the incidence of trauma to your teeth. Please also limit alcohol and don't smoke or chew tobacco. And if you need help quitting, please contact the Quit line on 131 848, or contacting your general practitioner, pharmacist, or oral health professional with help on quitting. Thank you for your attention, and I hope you are able to take at least one message home today and try and practice it in your daily oral hygiene routine. Thank you.
Thank you so much, Juliette, for that fantastic session. I will definitely do those exercises while I'm watching TV tonight, so thank you very much for that. Now I'm really pleased to introduce our next expert, Dr. Jessie Huang-Lung, who will be guiding us through eye health as we age. Staying vigilant about our eye health is so important as we get older. Jessie is an optometrist and a researcher based at the University of New South Wales. Her research focuses on how teamwork and technology can make eye care more accessible and effective for everyone, promoting healthy aging and preventing vision loss. She's held clinical positions in various optometry services across Australia and is an alumnus of the Australian Volunteers Program, where she contributed to the development of optometry education. So please join me in welcoming Jessie to the stage.
Good afternoon, everyone. Thank you for the invitation to join in on this session this afternoon. So before I begin, I also would like to acknowledge the traditional custodians of the land in which we are meeting, the Gadigal people, and pay my respects to elders past and present. So as Gohar mentioned, I am currently based at the School of Optometry and Vision Science at UNSW. So we are located on Kensington campus, and we have a couple of functions. We are involved in research, so we have clinical and lab-based research. We're also involved in teaching, so the next generation of optometrists. And as part of that teaching, we have an optometry clinic on campus where we provide services to the community for eye examinations. So, for today's talk, I was tasked with presenting on three sort of general topics. So the first is to cover some common eye conditions that present in people 50 years and over, some general advice on how to look after your eyes, and a little information about how to access preventative eye care. So on the first topic, just about the main causes of vision impairment in older Australians. So this is drawing on data from the National Eye Health Survey, which was conducted in 2016. So in non-Indigenous Australians aged 50 years and over and Indigenous Australians aged 40 years and over, what they found was the most common cause of vision impairment was from uncorrected refractive error. And that's to say that can be corrected with a pair of glasses. The second most common was cataract, and usually to restore vision, that would involve cataract surgery. For the next three conditions, age-related macular degeneration, diabetic retinopathy, and glaucoma, unfortunately, these conditions can cause irreversible vision loss. So it's really important to have early detection and early treatment to prevent vision loss caused by these conditions. So let's go through those conditions in a little bit more detail. So in terms of cataract, I'm sure everyone has heard of cataract. It's very, very common. And what it is caused by a clouding of the lens within the eye. So we've got two images here, a normal eye on the left and an eye with cataract on the right. So we've got images from front on and below are cross-sectional images of the eye. So in the eye with cataract, you can see that there is clouding of the lens just there. And what that causes is the light that's coming into the eye to become scattered and results in a blurry image landing on the back of the eye at the retina, which is where our light-sensitive cells are. So I suppose the key point that I wanted to mention for this is that optometrists as primary eye care practitioners can diagnose cataract. But having mild cataract does not necessarily mean that you need to progress to surgery. It exists across a spectrum. So what an optometrist can do is monitor the cataract and discuss with you when surgery might be recommended. And that's usually when it has an impact on your quality of life. when you're not able to complete the activities of daily living that you would expect that you need to do. So at that stage, when you are considering surgery, you're happy to proceed with surgery and it's impacting on your life, that's when an optometrist can refer you to a specialist to discuss surgery as an option. The next condition I wanted to cover was age-related macular degeneration. Again, a very common condition. You may know someone who's impacted by this condition. So it's a progressive eye disease that causes central vision loss. Our central vision is affected, and that's what the macula is responsible for. So for this, in terms of the stages, there are 3 stages, but what I wanted for you to understand is that the early and intermediate stage has minimal or mild impact on your vision, and it's more common. So what we find is drusen, or these sort of fatty yellow deposits at the macula. So early intermediate stage, you may not notice any symptoms. It's really in the late stage, which is not as common. So 1 in 100 Australians aged 50 years and over are estimated to be impacted, where people really notice a change in their vision. So this is an image of an eye with late-stage macular degeneration. So to give you an example, so it's not a complete blackout of the vision at the centre of your eye. To give you an example of what it might look like, here is an image of someone with normal perception on the left side and someone with late macular degeneration on the right side. So you can see in the centre of the image things are a bit blurry. There's sort of shadowing of the notes that are being held in the hand there. So the key point for this condition I wanted to share with you was that about the major risk factors for macular degeneration. They include age and family history, so 2 things that you can't modify, can't change your family, can't change your age, but the other major risk factor is smoking. So basically quitting smoking can really reduce the risk of developing macular degeneration, and if you have the condition, and can reduce the progression of the condition to the late stage. Okay, so the next condition is diabetic retinopathy. So quite common in people with type 1 and type 2 diabetes, and diabetes we know affects about 5% of the population of Australians. So what happens because of the elevated sugar, there's damage to the blood vessels in the retina. And you can see in the image, this eye compared to the previous one, perhaps you can perceive that there is some bleeding and there's these reflective yellow spots on the retina. So they are leakage from the blood vessels causing those signs. So again, this condition exists on a spectrum. We've got early stage where patients are asymptomatic. They don't notice any changes to their vision, and this progresses to a vision-threatening stage and then eventual vision loss. So some risk factors: the longer you've had diabetes, the more likely that you'll have some signs of diabetic retinopathy. So after 20 years of having type 2 diabetes, we expect 60% of the patients will have some sign of diabetic retinopathy. So other risk factors for diabetic retinopathy include poor sugar control, high blood pressure, and cholesterol. So it's important to have those risk factors managed with your GP. So the key point for this one is that regular eye examinations are important for early detection of these changes to allow you to modify those risk factors, sugar, high blood pressure and cholesterol, so that you can reduce the risk of developing these vision changes. Okay, and the last condition that I wanted to share or speak about this afternoon is glaucoma. So this has been coined the silent thief of sight, and that's because many people who have the condition will not notice any changes to their vision until they have quite late-stage disease. In fact, about 50% of people who have glaucoma in our communities don't know that they have it, and it's estimated to affect 1 in 50 Australians. So it causes progressive damage at the optic nerve, and it's linked to eye pressure, but that's not necessarily the only cause, but it is linked to it. And the risk factors include age, family history, up to 10 times the risk of having glaucoma if your direct relative has it. So that's a sibling or parent has glaucoma. Short-sightedness is a risk factor, and so is diabetes and sleep apnea. So the key point for this one is that glaucoma, although it doesn't have a cure, early treatment, which basically to reduce the pressure in the eyes, typically by eye drops or laser, can slow the disease progression and prevent vision loss. So the images here on the left, again, sometimes we see images in the online, for example, where there's a complete loss of the side vision reflecting glaucoma, so tunnel vision. But I suppose what I was trying to show is that this may be a more realistic portrayal of what glaucoma might, how it might affect someone's vision. So in the bottom image, you can see there's sort of blurry patches across the field, which is not as noticeable as if you were to develop sort of a blackout tunnel vision, which is sometimes how it's portrayed. So yeah, the eye examination is a way that optometrists perform, is a way to pick up really early signs. So next topic was looking after your eyes. So some of the advice here is really similar to what Juliette had mentioned before. So eating a healthy diet. It's been shown that, for example, for macular degeneration, eating a healthy diet with green leafy vegetables, lots of different coloured vegetables, red, orange, and yellow, can help prevent progression of the disease. And in terms of exercise, that's generally to reduce the risk of other systemic conditions, for example, diabetes, but there has been a link with, say, glaucoma as well. Quitting smoking, as I mentioned before, because smoking is a major risk factor for macular degeneration. It's also linked to other conditions like cataract, and wearing a hat and sunglasses when you're outside, because the UV light can cause or is linked to cataract development. And finally, having regular eye examinations. So an optometrist is a primary eye care practitioner, your first port of call if you have any concerns with your eyes, and they are throughout the community. So if you might already have one, if you don't, this is a little tool that the Optometrists Association of Australia has put together. There's a QR code to access this website. Basically, you can put in your postcode, and so for this example, I put in the postcode of Balmain, and it shows you a list of optometrists that might be in that local area. So optometrists do bulk bill Medicare for eye examinations, but my recommendation would be to check before you go in as to what their billing arrangements are. But for people aged 65 years and over, Medicare does subsidise eye examinations once a year at the full comprehensive rate. So that is the end of my presentation, and I'll look forward to questions later. Thank you.
Thanks so much for that, Jessie. Really appreciate it. And it was good to hear about those preventative tips on how to keep our eyes healthy as well. Thank you. So next up, we have Zainab Al-Modhefer, who will be talking to us about the importance of foot health. And we all know that foot health plays an important role plays an important role in maintaining mobility, preventing serious complications as we age. So Zainab is an Associate Lecturer in Podiatric Medicine at Western Sydney University with 9 years of clinical experience. Her research primarily focuses on diabetic foot disease. She also has a keen interest in other areas of podiatry and Alzheimer's disease, and her current research explores the role of footwear in people with diabetes, specifically for preventing ulcers. In addition to her research, Zainab teaches podiatry and surgery subjects at the university and works as a clinical supervisor at Western Sydney University Community Uni Clinic. She's passionate about teaching and advancing the profession and ensuring that patients receive excellent foot care. So please join me in welcoming Zainab to the stage.
Thank you everyone for having me today here, and thank you Gar for your invitation. It is an honour to be here today and to talk to you about foot health, which is really important. And you will find there is a lot of similar themes of what Jess and Juliette were talking about in terms of managing conditions. So we'll go through that in a little bit. So just before we start, just an acknowledgement of country. I pay my respects to all elders, past, present and emerging, and acknowledge the traditional custodians of the land. So Koha gave a really good introduction. So I do lecture at Western Sydney University. I also do clinic supervision for students that are training to be podiatrists. I have been a clinical podiatrist now for 10 years and doing research in diabetes and sometimes in Alzheimer's disease. So, foot health as we age. So basically, what are the problems that we kind of encounter as we age? Unfortunately, it's a process that we can't stop. So a few things start to kind of decrease over time. So the first thing you have is skin. So the skin layer and thickness of the skin reduces. The joints and the articular cartilage get overused over time, so they thin out and reduce, making you more prone to osteoarthritis. Muscle strength and mass is also reduced, so a condition we call sarcopenia, and I'll go through the effects of that in a little bit. Fat loss. Nobody would have thought that losing fat would be a bad thing, but yeah, unfortunately, in certain places it is. So around that fat pad on the foot, just there. So where you actually walk, if you don't have enough cushion or enough fat pad there, you're basically walking on your bones, and you're more prone to ulcerations and corns and other skin conditions. Bone density and mass is also reduced because of the reduction in calcium and other minerals. So with that reduced bone density, your bones are more brittle, are more prone to fractures. There's also spinal changes, so that affects posture. You do lose a few centimetres on height, unfortunately, due to that compression in the spinal column. And the changes in those bones, the muscles, it does causes about a bit of imbalance when you're walking, and that affects gait and how you walk. It also affects how long you can walk, and that affects mobility, and puts you at risk of falls as well, which is a big thing. Loss of muscle mass, so leads to that fatigue, weakness, and unable to tolerate exercise really well. Cartilage, osteoarthritis starts to come up in joints. So in areas where there's surgeries or previous injuries, osteoarthritis tends to occur more rapidly just because of the trauma in that area. And ligaments also lose their flexibility, so that contributes to joint stiffness. So all of that kind of affects mobility as a whole. In terms of the skin, so the skin loses that elasticity, it becomes drier just because of the impaired barrier function and the decrease in sebum and those oils that moisturize our skin. Our nerve endings also decrease and our sensation is diminished, so our feeling is not as good as it should be, which is a problem, especially on the foot, because you're walking on that area. And if you don't have that protective sensation, it puts you at risk of injuries that you're not aware of, and ulcerations as well. So the blood vessel perfusion also decreases to areas. Sweat glands don't produce sweat as much. So again, that will not allow the body to kind of adjust their temperature properly, as well as making the skin a lot more drier. Melanocytes also decrease, so you don't have that kind of protection against the sun. All of these kind of changes make a big impact on how the skin actually heals and is damaged over time. So what can we do? First thing with mobility is exercise. The more that you exercise, the more that you can mitigate some of those changes, because you'll be using those muscles, building up the muscle mass. So resistance training is really good. Aquatherapy is excellent because it doesn't put stress on joints, because the water will take away that kind of weight-bearing effect. And also the water will create that resistance, so it kind of builds up the muscle mass if you do exercise in like aerobics, well, not aerobics, but kind of like aqua classes. Sometimes physiotherapists will run sessions like that, or exercise physiologists as well. With the skin, sunscreen is your biggest protection against the UV light and that damage that UV light causes from especially the Australian sun. Wearing protective clothing, moisturising, so mitigating that the dryness that comes from the lack of secretions over time. So moisturising on a regular basis, daily. Gentle cleansing and exfoliating the skin as well, so you don't have that build-up of dead skin cells. And visual checks regularly. Going back to that point about when the nerve endings don't work as well, so you don't have that protective sensation, you have to rely on visual inspection to check that you don't have any wounds or anything on the foot or in between the toes. So I'm going to go through some common skin conditions. Some of them can be a little bit gross, so just a forewarning. But things that you should check your feet for. First one is fungus. This one's a big one. Where does it come from? So the biggest one is cross-contamination, because it is contagious. So areas that are communal, so it's like swimming pools, hotels, like hotel bathrooms, if you go to lockers in gyms and you don't wear, you go barefoot in the showers, especially in moist environments, that's where you kind of pick up that fungus. Another big one is nail salons. Now, nail salons, majority do not sterilise the instruments, and that can cause a lot of cross-contamination between patients. So same thing with nail polish. They use the same nail polish and brush on everybody. So what I like to say to patients is that bottle of nail polish is a breeding ground for fungus, and it sticks to your nail to breed. So it's not great, it's a bit gross, but it's things to be aware of, because fungal nails are really hard to treat. If you try to treat it with topical, it takes about 12 to 18 months to kind of see a difference. Even with oral antifungals, it's a bit of a problem because they do cause liver damage, so it's not really recommended. But again, you still have to wait for the nail to grow out, which is 12 to about 18 months. So it is a pain, and in that time, it gets reinfected, so you start all over again. So it's a very hard infection to treat, and if you do have other chronic conditions, it makes it a lot harder because your immune system would be compromised as well. Other places that you can contact it from is closed-in shoes. So if you're in shoes all day, same pair of shoes, that moist environment, that darkness is that breeding ground. And that's the same thing for tinea as well. So the fungal infection of the skin. So how do we manage it? So if you do have closed-in shoes, air those inner soles out, take them out. If you have two pair of shoes that you can alternate between each pair, if you're wearing every day, that would probably be a good thing. You can use Glen 20 or tea tree oil to spray inside the shoes as well. Avoid the nail salons. If you do need to see someone for nail and skincare, you can always go to your local podiatrist. Avoid sharing tools, socks, shoes with anybody else, especially those that are infected. Use thongs for communal places, so make sure you pack those thongs if you're going on holiday, even in hotel showers, in gyms, in swimming pools, all of that. Drying between the toes. Also, using Caniston laundry wash. So I've got it here. Does this work? Yeah. Yeah. So I usually use that with all the laundry as well. I just put 1 cup in there. So it really helps kind of to kill off all the fungus, especially in the socks. And see your podiatrist for treatment. Next one is warts. So caused by the human papilloma virus or HPV. It's exactly the same as fungus. That's the same places that you pick it up. In terms of treatment, you have to see someone for treatments, preferably your podiatrist, because they have a range of treatments. If you see the GP, they usually go for cryotherapy, which doesn't really have a very successful treatment rate. There's also acid therapy, Swift, microwave therapy, needling. There's a whole range of treatments, but it comes down to one thing: immune system. So if the immune system is not operating well, it's very hard to treat warts. Sometimes if your immune system is doing well and the area is irritated, the immune system will just get rid of it. Other times it can go for weeks and months of treating, especially if your immune system is compromised by other chronic diseases or medications. In terms of foot hygiene, exactly the same as the fungal management. Other more common conditions that you will see is corns, calluses, and cracked heels. So your corns and calluses are mostly from pressure. Corns are more focal pressure points, so either there is pressure from the shoes, or if you have a prominent bone, anything that puts a lot of stress on the skin will automatically try to build up hard skin on top to protect it. So those kind of manifest as the corns and calluses. So as you would imagine, the way to kind of manage that would be to offload those areas and reduce the pressure to reduce the growths of the corns and calluses. So a lot of the times it's also biomechanical disturbances. So the way that you're walking, putting pressure on certain points on your foot will create certain pressure points. Also, if you have any deformities, so things like bunions, clawed toes, all of those things can also create different pressure points. The footwear, if you're not wearing good shoes, that doesn't have good shock absorption, can also create some pressure. In terms of cracked heels, also caused by pressure, also a lot of dryness, and that's as we age, our skin gets more dry. So what will happen is it will come up as these fissuring in the skin and the hard skin on there. So that will also open up and start to bleed, and it can be very painful to walk on and can get infected. So if you do have that on your heels, it's very important to actually get it treated. Also open footwear, if people are in sandals all the time or thongs and you don't moisturize regularly, all of those things can cause the cracking of the heels. In terms of management for this, so with corns and calluses, they have to be removed by a podiatrist. A good thing is to go in for a biomechanical assessment to see where your pressure points are at as well. So that way, the right footwear can be recommended. If you need orthotics to offload certain areas, all of those things can be kind of assessed in that biomechanical assessment. Please don't try to remove at home. I've had some weird and wonderful stories from patients of how they tried to remove their corns and calluses, ranging from power tools from Bunnings to scratching their heel on concrete, to getting the dog to lick it off. That was a recent one. Somebody told me a few days ago. So yes, please don't remove it yourself. Do go to someone, so like a podiatrist, to actually get it removed. It is painless. And you will probably enjoy a good chat as well with your podiatrist. So it won't be painful, so don't worry too much about that. In terms of in terms of cracked heel, you will need a stronger moisturizer. So normal moisturizers like Nivea or Sorbolene won't cut it. You'll have to go for something a little bit stronger with urea, so something like a heel balm, and that will help get rid of the cracking as well. If you do have a buildup of callus around the heel, that needs to be removed. Good footwear, which I will discuss in a little bit, and also, like I was saying before, because of these conditions caused by pressure, we want to offload the pressure by padding and cushioning. Now, I'm going to talk about, there's so many chronic conditions I can talk about that can manifest in the feet, but I'm going to concentrate on diabetes, just because it is so common, and it's the complications of diabetic foot disease can be quite significant. So diabetes, there's two types of diabetes. You've got type 1 diabetes, which is an autoimmune condition, and type 2 diabetes, which is more of basically the body becoming insulin resistant and not being able to process insulin effectively. So over time, type 1 diabetes, you will need kind of like to manage insulin straight away. Type 2 diabetes can be managed by medications, but over time it will require insulin as well. The complications that I want to talk about with diabetes is a few. So the first one is nerve damage, or what we call a diabetic peripheral neuropathy. Similar to what just was talking about retinal neuropathy as well. So it's the same kind of principle. There is damage to the circulation, to the lower limb and to the feet, and also will lead to nerve damage. So what happens is, over time, you will stop feeling the bottom of the foot. It becomes numb. There's feelings of burning, electrical feelings. When it gets quite severe, it does keep you up at night. And that lack of protective sensation puts you at risk of injury. And because of that you can't feel pain, who would have thought feeling pain would be a blessing? Basically, wounds go unnoticed. So they get infected, the infection gets to bone, and that's where things like amputations kind of result. So it's actually quite serious, and it does progress quite quickly, especially when it goes unnoticed, because you can't feel pain. And pain is the body's way of telling you that there's something wrong. So coupled with that with poor circulation, so that damage that occurs from high blood sugar levels, damaging those blood vessels, reduced blood flow means that you can't heal very well. So slow healing will cause the wound to stay open for longer and more prone to infection, and it doesn't heal very well. It also affects the immune system fighting off those infections. So those two complications leading to things like ulcerations can then lead to amputations. I've actually had a patient that once came in, and he came in for his first time patient, but he wanted his nails cut and his skin looked at. So he didn't know he had a wound that was about this big at the bottom of his foot. So he had no idea. He could not feel his feet. And it was very deep. It was down to tendon. I had to send him to the hospital. Because I can't really treat that, he will have to get it looked at, and most likely would lose his foot in that case if the infection was because it was infected that severe. So it is quite a silent progress, but it is a bit catastrophic when it does happen. So that's what I talked about in terms of foot ulcerations. When you do have, so nerve damage and poor circulation can also lead to changes in the way the structure of the foot is. So it leads to more claw toes, that kind of higher arch deformity, and pressure points as well. And that puts people at risk of ulcerations, because then if you've got really high pressure points, the skin breaks down. So that's kind of like a bit of a complicated diagram showing about how high blood sugar levels and diabetic neuropathy and peripheral arterial disease, which is the loss of nerves or sensations in the feet, as well as the lack of blood flow, can all lead to things like deformities, ulcerations and amputations. So I know that was a bit morbid. So and it is a very necessary kind of education, so people can know what the complications are with these kind of conditions. And peripheral neuropathy is not just in diabetes. It can occur from a lot of things. It can even occur as a side effect from long-standing cholesterol medications. It can occur from back injuries. So it is not just diabetes related. It can have different sources as well. So what should you do? See the GP. That's the first thing, and get that management plan done for any chronic condition. Book in to see your podiatrist. They will do assessments to check your circulation and nerves and make sure that everything is all good, as well as a biomechanical assessment to see any pressure points and any issues with the feet. Check your feet every day. So basically that visual inspection is really important because you can see things that you can't feel. Any open wounds, antiseptic and dressing, monitoring. Skin integrity. So very important to moisturize to maintain that skin integrity, because dry skin is easier to scratch open, whereas kind of strong, pliable skin is really hard to. And wearing good shoes. So in terms of footwear, what do you want to look for? So it depends on your foot really, and what you want to do is basically look at your foot shape and see if you do require wide fitting shoes. The width is really important because you're not going to get scratching or kind of like on the side of the feet that can cause blisters or corns or ulcerations if you are a high risk of those kind of conditions. So, and deep enough as well, especially if you do have some sort of deformities like claw toes, you need a deeper toe box to kind of like accommodate those changes. Shock absorption is really important, so making sure that shoes have those layers where pressure from the ground is going through those layers before it reaches your foot, so that puts less stress on the joints and the skin. In terms of fastening mechanism, that will be up to you what you prefer. Laces is always the best because it's adjustable and you will have the most support, but there is like Velcro, there's zippers now, there's a lot of different fastening mechanisms that makes it a bit easier to put shoes on and off. And the other thing is stability. So what you want to do is make sure that your shoes are stable and they're not soft. So you're not basically wearing socks where your foot is going backwards and forwards when you're walking. Some of the brands that I would recommend is for sports shoes. I would recommend Brooks are pretty good. Saucony, Asics, Mizuno's, Ascent. Ascent also have really good casual shoes as well, or black leather shoes. If you want something a little bit more of a nicer look, Sierra's, Baird, Author Heel have a big range. Dr. Comfort do make orthopedic footwear, so their shoes are pretty good. And Revere, so Revere and Scholl, they do kind of do sandals that are kind of orthotic friendly, and they do have kind of a supportive inner sole as well. How do you access podiatry services? So you are eligible if you do have a chronic condition for 5 visits per year. So this is across all allied health, and you just have to see the GP to write up the plan for you. And basically those 5 visits last you from January to December before they roll over in the next year. There's also health funds and private but you don't need a referral. If you do need to contact me, my LinkedIn is here. If you can kind of email me if you like. And yeah, thank you for listening.
Thanks so much for that, Zainab. That was very informative indeed, and I will definitely be looking up the shoe brands that you've recommended as well. We're just going to get the stage set up for some Q&As, and so just bear with us for a minute while we get it sorted. Start with Juliette. Juliette, one of our regional people have written in and they're asking about, they've got a pension card and they're wanting to know where they might be able to get discounted, if there's a Medicare scheme for oral health or if there's some sort of scheme that they might be able to tap into.
Yes, so thank you for the question. If you're a pension card holder in New South Wales and also a Medicare card holder, you are eligible for public dental services in your local health district. So you can just look up on the New South Wales Health website, oral health services, and there's a 1-800 number which you can call and they will link you to your closest local health district clinic.
Excellent, thank you. I'll go to the audience to see if there's any more questions from the audience. Excellent.
I have a question for each of the speakers. They will know which one is relevant. I'd like to know about exfoliation. Like to know how to brush a tongue. And I'd like a comment about the phenomenon of occasional double vision.
All right, we'll start with exfoliation. Over to you, Zainab.
So with exfoliation, just gentle exfoliation, nothing too abrasive. So you can use a loofah or just a sponge to remove the dead skin cells on the surface of the foot. Does that answer your question?
Excellent. Then we'll move on to brushing the tongue.
So brushing of the tongue can be done by a toothbrush. So just after you finish brushing your teeth, using the head of the toothbrush to clean the top of the tongue. There are tongue scrapers, metal tongue scrapers that you can use, but it's just personal preference which one you can tolerate. Sometimes it's easier just to use what you've got in your hand, which is a toothbrush, and just brush the top of your tongue afterwards.
Just on that, Juliette, sometimes you can buy those toothbrushes and they've got a tongue cleaner on the back of them. Are they a gimmick, or is there any difference between using a brush or using a special?
I would say depends on the thickness of the little filaments on the back of the toothbrush. Some might be longer than others and be able to penetrate the hairs on the tongue and clean all the plaque off more effectively. But because the bristles of your toothbrush are quite long and soft, they're probably better at cleaning all the little nooks and crannies in our tongue than the back of that toothbrush.
Excellent, thank you. And double vision.
Thank you for the question. Thank you for the question. You're testing my knowledge. There's lots of different types of double vision. So we need to, if it's not, we usually classify if it's constant or intermittent. And from what you're saying, it sounds like it's occasional. If it's constant and it's a sudden onset, that's a real concern. It could be a nerve palsy, for example, and needs urgent attention, like a presentation to ED. In terms of occasional, it could be dry eye, for example, if there is drying of the ocular surface, which is causing the light to be dispersed in a way that you get sort of double vision, and then when you blink, it clears. It could also be to do with how the eyes are working together. So you might be getting different images from each eye if, for example, they're not pointing to the same place. And
that's what's happening.
Yeah. So So I suppose, yeah. Did you have a follow-on question about it? So it could be the way that the eyes are not pointing in the same place, which can be more so when you're tired, for example.
That's what I've found, but it's unreliable. Sometimes I can be very tired and have good vision, or I can be not tired at all and have double vision.
Yeah, I mean, we probably need to do a full binocular vision workup to test how the eyes are moving and working together. And there are a series of tests that can be done. There are prisms, for example, that can be prescribed if there is some sort of a little bit of weakness in the muscles to help the eyes to align the images. But it's a little bit tricky because it's occasional. So would you want to be wearing those all the time? So it's something that would need to be worked up with a full test and then consider what the options for prescription are.
And the appropriate authority technician is a optometrist?
Yes, so an optometrist can help you with that. Some have a more sort of special interest in binocular vision disorders, and so we could refer to someone if we weren't sure. But all optometrists are trained in how to assess binocular vision, so definitely that can be done.
Those were great questions. Thank you. I think we had another question up the back.
My question is for Juliette. Would you make some comments about electric toothbrushes? Yes. Thank you.
Anything in particular about electric toothbrushes?
Well, whether it's therapeutically good or better than the toothbrush that we normally buy.
Okay. So
and how often should you change the brush, etc., etc.?
Yes. So with an electric toothbrush versus a manual toothbrush, there are studies, especially from Cochrane Institute, that electric toothbrush is advantageous over a manual, but that can also depend on your dexterity and how you are trained in terms of knowing where to brush and how to brush the whole mouth effectively. So you can achieve the same thing with a manual toothbrush as you would with an electric toothbrush. I personally do recommend electric toothbrushes because the size of the head of an electric toothbrush is much smaller. It's round, it spins in the correct motion that we do educate our patients to brush in, which is the circular motion at the gum line. And it can reach those hard to reach areas in the back of the mouth and behind the lower front teeth as well. So personally, I do recommend electric toothbrushes and feel that they can get a better clean. And it does have a timer on most of them that times you for the whole 2-minute brush, breaking up the mouth into separate sections. If you wanted more in-depth videos on how to use your electric brush correctly, the Australian Dental Association has very good videos on how to use your brush correctly. In terms of changing the head, I would recommend as a manual toothbrush 3 to 4 monthly with a change of a season. And if the bristles become splayed, so they're all worn and tattered, and also if you had cold or flu or COVID, any other acute respiratory infection.
So Juliette, if we're brushing our teeth for 2 minutes with an electric toothbrush, is that the same amount of time we should use for a manual toothbrush, or is there a difference there?
No, the same amount of time, but it's just that some electric toothbrushes prompt you to move to the next section of your mouth every 30 seconds. So essentially what the electric toothbrush does is breaks our mouth up into top and bottom halves, right and left sides. So we've got 4 sections of the mouth, top right, top left, bottom left and bottom right. Each of those quarter sections, we call them quadrants, will be 30 seconds. So that adds up to 2 minutes in total. So electric toothbrushes do vibrate at that 30-second mark to tell us to move to the next section. But a manual toothbrush, obviously, we just have to use visual reminders, maybe use a timer on our phone. But the electric toothbrush will tell you when to move on.
Excellent, thank you.
Yeah, so you can, base models start from $0 to $50 and they do spin at maybe a lower rate than some of the more expensive models. But more so, the expensive models have just extra functions that might tell you you're pressing too hard. It will have a red light that flashes to tell you that to ease off your pressure. It might have functions that lighten up the pressure in terms of sensitivity. If you have very sensitive teeth, it does have an ultra-sensitive mode. And just things that connect to your mobile device as well with the more expensive ones. So definitely don't need to spend too much to get the same result. You can spend up to $50 and still get a good clean.
Thanks for that. I think we've got another question down here.
This is to the podiatrist. I'll tell you a story, and I'll tell you, I had a job, I didn't like it. I developed a fungal growth on my left toe. I went to the doctor, I took antibiotics, I used TT oil, I used everything. I had a fungal infection in my foot. I had a fungal infection on my big toe. I was in a job I didn't like. I had an hour travel there and back. I went to the doctor. I took antibiotics. No results. I took tea tree oil. No results. I tried other things. No results. Then one night I broke my foot because I couldn't stand it. I accidentally went to the bathroom and went into a wall instead. If you don't do something, accidents happen. So I had to leave. Within 3 months, my fungus disappeared. 3 months gone. And I went to an energetic healer and they said, you couldn't move forward and your body didn't like where it was at, so it made the fungal infection. When you had the accident and you left, within 3 months, it went like that. It grew out. So my question is, do you take energetic understanding of the holistic body when you're treating patients for situations like fungus or other sort of soft problems?
Sorry. So definitely, when you were talking about the job you didn't like, I'm guessing there was a lot of stress involved. So stress causes cortisone to increase in the body, and that will will dampen down your immune system. So things like fungus or warts kind of wreak havoc because it's kind of a free party to them. They don't have the immune cells kind of keeping them basically at a certain point where they don't become too infectious. So once that situation was resolved, your immune system was able to fight off that infection. So I've seen that all the time, and there are certain points in time, like patients that have come to me. For example, one time a pregnant woman, she had a wart that was not responding to any treatment, and I basically just said, because of your immune system being affected because of the pregnancy, you'll have to probably wait, because we can keep treating it, we can keep coming every 2 weeks, and it's not going to basically come up with a solution. So we'll wait until you give birth and start taking multivitamins, get your vitamins up to scratch basically, and then come back when your immune system is in a better position. And sometimes they just go on their own as well, just like in your case.
It was, if you don't move, if you're blocked moving forward, the body will manifest a disease.
Yes, definitely. Stress will basically come out in a physical form. Yep, definitely.
That's a great reminder about how mindfulness, making sure that we reduce the stress probably has a holistic impact on your health and can really benefit from those kinds of not just physical and taking medication, but thinking about how we can lower stress in life to stay healthy as well. I've got another question down here.
I've got my good shoes on.
I'm judging.
Sorry. You mentioned exercises for the mouth, but I would like to know if there are special exercises for the eyes and the feet that we can do to improve our health.
In terms of the feet, the big ones that I would recommend all the time is your calf and hamstrings, so lower limb. If you really want to work out like the small muscles in the feet, I would like picking up a towel or marbles off the floor, just doing range of motion exercises, just going up and down, side to side, those kind of things. The best one is walking on the sand. That will, excuse to go to the beach, yes. So that will actually train, will provide that resistance and also that imbalance that causes the muscles to actually work harder to get the body in a balanced position, so that will make the muscles stronger. So walking on the sand will actually do a lot. In terms of hamstrings, basically you're just straight like this. Yeah, just in bed you can do a towel and do a deeper kind of stretch. With the calves, you can actually do it while you're sitting down. So one knee bent, one straight, and just coming down on that straight one and just bringing your foot upwards, and you will feel it at the back.
Over to Jessie for her exercises.
Oh, yes. Thank you for the question. I suppose the exercises could prevent some visual strain. So things we often recommend is looking up. I think this 20-20 rule. So looking out at something that's 20 meters away for 20 seconds every 20 minutes. If you're doing a very demanding visual task, that can help to relieve some of the eye strain that's associated with long periods of looking in close up.
That's a great tip. 20-20-20, nice and easy to remember as well. I think we've got another question over at the back here.
My question is to Julie. I do Sensodyne gum-based toothpaste. What I like to know is, in addition to that, I also use mouthwash, Listerine or Saracol. If so, which is better, and how often do I have to use the mouthwash?
In terms of mouthwashes, we don't recommend that they're necessary to use every day. The main aim of cleaning our teeth is using the toothbrush with toothpaste to physically remove the plaque. Any mouthwash that you do use could have a topical antibacterial effect, which maybe you've got some localized gum swelling or gingivitis, you might see bleeding on brushing. I would only use those maybe for 2 weeks while you've got a bit of that inflammation to help it heal. And then after that 2 weeks, you probably don't need to use the mouth rinse again. If you do like to use a mouth rinse, maybe I would use it after mealtime. So maybe after lunchtime, in between the day when you're out and about, to just freshen the mouth and remove the food debris. And also go for an alcohol-free containing mouth rinse, because the alcohol in a mouth rinse can dry out the tissues of the mouth, and we don't want to have the dry mouth because of the risks that we spoke about before. Yep.
They're great tips, thank you. Any other questions? Great, we've got one over here, and then we'll go over here.
Oh, thank you. Yes, I'd like to know, I don't know if this is appropriate, but can anything be done about floaters in your eye? Because is it related to cataracts or anything?
Yeah, so the floaters are situated in the vitreous body, generally, which sits behind the lens. So normally when we're born, it's nice and clear. It's basically a body of collagen. Over time, those collagen fibers kind of break down, and we might start to see a few more floaters. Another thing can happen, which is called a posterior vitreous detachment. So the vitreous is attached to the optic nerve, and it's really common for it to come away all of a sudden, and you would notice a lot more floaters all of a sudden. And that's a bit concerning, but it's actually very common. And in most cases, it doesn't result in anything that requires further treatment. It is annoying, though, to see those floaters there all the time. So when that happens, it's important to have the eyes looked at. So you would normally put drops in the eye, dilate the pupils. An optometrist could do this and make sure there's no signs of retinal tear or detachment. So once that's over, what the brain does is actually sort of gets used to the floaters over time, and they can be a little bit less bothersome. Unfortunately, there's not a whole lot we can do about floaters typically. If they're not so bothersome, we tend to leave them there and you adjust. There is a new sort of vitamin that's available on the market, which you can purchase from some optometrists. I don't know exactly who stocks them, but I know it's available. I think it's a course of multivitamins, which overseas in some studies, they showed that it reduced the patient's symptoms of the floaters, but they tended to be prescribed in people who were really, really, really bothered by the floaters. I think it's a 3-month course, a 2-month or a 3-month course that you would take. So that would be something you could discuss with your optometrist if it's really bothering you. But otherwise, to remove the vitreous, that would require surgery, and it's not a step we usually take with floaters. Only if you had a retinal tear or detachment that needed fixing with an ophthalmologist, they would use, that would be surgery, then they might remove the floaters at the same time. That's okay.
Excellent, thank you. So we've got, okay, so 1, 2, and then 3 at the back. And then we'll go down here again.
There were 2 photos. One was normal vision, and the other one was glaucoma. And the only difference I saw was the glaucoma was clearer. What's the difference?
Sorry, that didn't come through. Yeah. I suppose that's part of the point I wanted to make, that in the early stages, or even with the moderate stage, it's not that noticeable, the changes. So what was actually in the photo, the top one was supposed to be the clear one. And the bottom one had sort of blurry patches. So some of the signs or like the corners of the buildings, like you couldn't see the detail that you could, or with the car perhaps.
To me.
Yeah, sorry, maybe that was just bad images, but...
We'll have also the video available, so if you'd like to, we'll let everyone know when it's up, if you'd like to go back and have a little bit more of a look and see what the differences are there as well, that'll be available as well for everyone.
And may I suggest something for fungal toenails? Miso.
What is it, sorry?
Miso. Japanese miso.
Miso soup.
It works.
Really? Interesting.
You put the miso on the...
Yeah, just put a little bit on your toe.
Oh, and
over time. It takes
and
a
how
while.
long did it take to resolve?
Oh, about a month.
A month? Okay. I will look into that.
All these other topical things that you buy are completely useless.
Yeah, they do take a bit of time, and the problem
They don't work.
The problem is the reinfection in between. So you're waiting for the nail to grow out clear, and you're treating it as you go. So, and then it gets reinfected from, say, the shoes or the socks, or bouts of where you may be unwell from the flu, and then basically you start all over again.
And how long does the toenail take to grow out?
About 12 months if you're really healthy and you've got all the vitamins. So, it would probably be very rare that everyone has all kind of like where it's 12 months. It's usually longer. Yeah.
Okay.
Down here first. Sorry. Okay.
The question I want to ask is, I've noticed on the toothpaste, the bottom of the tube, there's a color there, and all different colors on different tubes. Can you tell me what are they for, and why is it there, and which one is the best one to use?
So I am not sure about this question, but I will have to look it up. But from memory, I think it's a production manufacturing related colour. It doesn't have anything to do with what's inside the toothpaste at all. But I will get back to Gohar with the proper answer on that when I find it.
Thanks.
Well, there was one I noticed got organic, and the other one is, I can't remember the color, but one is chemical, and the other one is, I can't remember, just 4 different colors.
Okay, yeah, I'll have a look specifically for the exact answer, and I'll get back to Gohar.
Anything in particular to look for a toothpaste though?
Mainly fluoride-containing toothpaste, and abrasiveness. In terms of whitening toothpaste, I wouldn't recommend those so much because they can be too abrasive and cause sensitivity. But any toothpaste containing fluoride is what you want to look for.
Excellent. Just over here, then we'll come down to the front.
I sometimes wake up with a metallic taste in my mouth. Is that something to be concerned about, or is it due to the lack of saliva while I'm sleeping? And the other question I have is also for the podiatrist. Do toenails thicken as you age?
If you do have vascular issues, there are a number of things that cause the toenail to thicken. First is trauma. So if you've dropped something or you bumped it on the edge of the bed, then the nail will thicken and grow a little bit strange. The other one is fungus, will also thicken the nail. Circulation issues. So if you have circulation issues, that will also cause the nail to thicken. Certain types of chemotherapy as well will cause damage to the nails and for them to go yellow and thickened as well. They do thicken sometimes over age, and that's just a uniform thickening. But if you're talking about really like bulky, thick, those other causes are probably to blame.
And then Juliette, the metallic taste.
Yes. So with the metallic taste, I think, do you generally have a dry mouth throughout the day? Do you find any? No. Okay. I would maybe. It could be related to gingival infections and maybe early signs of gum disease. So maybe I would check with your dental professional. Maybe just relay to them when it happens, if it's sporadic or if it's after you've had something to eat or drink. But yeah, maybe using a dry mouth gel or a spray before you go to sleep, just to keep the mouth moist and maybe prevent that from happening in the morning.
Thanks, Juliette. We've got a question just here.
Thank you, ladies, first for your lovely presentation. But I've got the old dry eyes, and from the eye hospital saying, do this in the morning, a hot towel, trying to get supposed to be something in the bottom of the eyelid. I've done that for months, and it got better, and then it came back again, and then I went on to drops, and antibiotics, and I'm still getting this dry eyes, that's watering. What I'm trying to read, and it's water running down my cheek. How do I stop that?
Sure, you're in very capable hands there with the doctors at the eye hospital, but when you talk about the water dripping down, actually that could be a drainage issue. We've got little drains in the corner of our eyes, which I suppose over time with age they can constrict a little bit. So sometimes there is a procedure you can do to dilate the drainage so that the tears are not running down your cheeks as you look down. And then sometimes they can become a bit blocked as well. So there is a procedure where they could clear the passage a little bit. In terms of the dry eyes, it's really, I suppose the warm compresses, it's good to continue doing them. And I know they might be a bit annoying to do, but you're still doing them. So basically they...
Oh, I gave up on that.
Oh, okay. It's just good for, it's kind of like brushing your teeth, I suppose. Not that often, but basically there are oily glands, which we call meibomian glands, that sit in the eyelids. And what can happen is that oil can get hardened and clogged, and so the heat sort of melts that oil, and that oil sort of sits on the top surface of your tear film, preventing it from evaporating. So evaporative dry eye is one of the most common causes of dry eye. So if we do the warm compresses and the massage to sort of let the meibum, the oil flow better, that is actually will help with the dry eyes, as well as drops if you need them. And with drops, we usually recommend doing them regularly, because unfortunately they only last a few hours on the eyes. So every couple of hours. And with our treatment paradigm, we start with sort of drops that are sort of try to retain the tears on the surface for longer. So there are like sort of stronger drops, as if what you were prescribed, you've been using for a while, is not working, then there is a stepped approach to doing other drops as well.
There's just one more thing. What is the temperature you use in this? I just use hot water.
Yeah.
But it has to be hot enough to make it work in the morning. But then it comes back the dry eye comes back and the reading. It's
Yeah.
been doing for 4 months now, all different ways.
Yes. Yeah, and I suppose it's one of those things that I guess it's a chronic condition. I suppose it's kind of here to stay in a way that we just have to manage. It's not like an infection where we would heal it and it would go away.
Oh.
It's something, with that is likely to hang around, and we just have to manage the symptoms. So.
Thank you.
Thank
Can I just say, say something about that? You can get this thing from this product from the optometrist. It's $40, and you can get a product from the optometrist. It's about $40, and you put it on with a mask and lay down for 7 minutes. And because it's full of little modules that stay hot, as you said, it melts the wax, because we have a natural bit of wax that comes down and conditions our eyes, and when it gets clogged, it doesn't work, and that's why your water's running down your face, because it's trying to lubricate them, but it can't. And just one question about feet. Why are my feet getting bigger?
Could be swelling.
I've gone up here, shoe size. All my beautiful shoes, they're tight now. What's going on?
So most likely it's swelling. So that can come from things like kidney malfunctions or issues, or high blood pressure, sometimes from certain medication. I wouldn't think it would be related to the glaucoma. It's mostly to do with just systemic, like if you have any other conditions that can cause your feet to swell, or even injuries in that certain spot. Sometimes the venous circulation or the lymphatic circulation is not working properly, so it doesn't actually get the fluid out and circulate it properly around the body, so the gravity pulls it down to the feet. So that's why you sometimes get swelling in the feet or swelling in the legs as well. So those kind of are the main kind of reasons, yeah.
Any exercises to help with that, Zainab?
Walking is the biggest one, because it gets your pumps at the back of the leg working, and that kind of helps with the venous circulation. Elevating the feet will help kind of drain them, so the gravity will kind of pull the fluid downwards, but if you elevate the legs upwards just a little bit, even if you're sitting in front of the TV or in bed, just a pillow underneath. Also compression socks. So if you don't have any circulation issues, you can use compression socks from the chemist, the ones that you use for travel. Yep. So compression can push the fluid back into it. There is also lymphatic massage that you can go and get to get the fluid pushed out manually as well.
Great tips, thank you. I think we had one other question, and I think we'll wrap it up there. We'll get to you.
Okay, thank you very much, ladies, for a very informative session. I've got a question for Zainab.
Yep.
You mentioned when we consult a podiatrist, we should have a biomechanical assessment.
Yes.
What exactly does that involve, please? Because I'm actually seeing one. I'm not sure if I was given one.
So it's mostly to see where areas of the foot can be impacted, but a biomechanical assessment will entail gait analysis, muscles, joints, basically posture, everything in terms of how you're walking, how you're standing, where the pressures are. So it will look at all of those things to kind of see where potentially the problem is. Sometimes people can come in with back pain. It could be from their feet, or knee osteoarthritis. It could be from the feet. So it's a holistic assessment and they'll watch you walk, they'll test your muscles, how strong they are, they'll check the joints, all of those things as well.
Excellent, thank you. And I think we've got one last question down the front here.
Thank you. Thanks very much. What my question is that how often do you think, like, how long will dentures last if you've got, find that you're getting pain, sort of like little mouth ulcers or things happening when you wake up in the morning, your mouth sort of hurts because probably the dentures or how you... I don't really clench my teeth a lot, something like that.
So just another tip, do you take your dentures out overnight when you're sleeping?
Yes, I do.
Yes, good. And when was your last checkup with a dental professional?
Oh, probably about 2 months ago.
Okay, so you're seeing someone regularly. Yes. Maybe any issues with dry mouth or...?
No, I don't have, no.
Yeah. I can't say exactly what might be the cause of getting the ulcers, but sometimes when dentures don't fit as well, they can be rubbing in the incorrect places. So maybe some dry mouth gel to help lubricate some areas, or also readjusting the fit of your denture might help with alleviating the ulcers. But I would just suggest seeing your regular dentist again, maybe if you're just experiencing that recently, to have your dentures reassessed and maybe other systemic issues going on. Yeah.
Thank you.
Excellent. Thank you so much for that. And I think that's all we've got time for in terms of questions. But I would like to say a very big thank you to all three of our speakers today. A round of applause for everyone. They were really amazing, and thank you so much for your time and your willingness to share your expertise with us. And thank you so much to the audience here today as well. Thank you for coming along, listening and bringing your questions along as well. I think it's been a fantastic discussion, so thank you all very much for that.